Hi guys, good evening, good evening, good evening. Wishing you everyone a Mahashivratri. I hope everybody is doing great. Welcome to another set of our BLS series. Today we are going to keep it absolutely short, and I've picked a very small topic for today's discussion. So today we will be talking about the obturator hernia. Now again, it's not a very common hernia. In fact, clinically it is very difficult to diagnose as well. The presentation is quite not there in terms of hernia, but again a very, very important context from the inguinal region. So we'll be talking about all the hernias. We have covered inguinal, we have covered femoral. So it is logical to cover your obturator hernia. So hence we will be covering our obturator hernia. Right? Now, when you talk about the obturator hernia, it has to go through some opening. Right? There's no canal here. There's a small obturator foramen or an obturator opening from where the hernial sac is going to protrude out. Now, for the sake of understanding, again, you have this is the pubic rami, this is the pubic tubercle, this is the pubic symphysis, and this happens to be your pubic bone. Right? Now, this is where you have the foramen that is present here. Now you will notice that here you will have the obturator membrane which is present. So the orientation of the obturator membrane to cover this area is going to be quite extensive. So this is how the obturator membrane will be present. So this is all your obturator membrane. It's more like a fascia that is present. So you will see the orientation of this fascia is present so that the muscles can attach, and this is how your obturator component is there. So this is your obturator membrane. Medially, within the obturator membrane, medially you will see that there is this small area which is not covered by this obturator membrane, and this is what we call it as the obturator foramen. Right? Now, or I can say the obturator opening. From here you will see there is a nerve that is going to come out, and that nerve is what we call it as the obturator nerve. Along with the obturator nerve, you will also see the obturator vein is going to travel. Along with the obturator vein, you'll have the obturator artery is also going to travel. So this small obturator's opening, you have the obturator nerve that is going to come out, you have the obturator vein as well as the obturator artery that is going to come out. Now it's a very small opening, so obviously anything that is going to come or it is going to protrude through it. Let's say there is a hernial sac that is going to protrude. Let's say the hernial sac is going to descend down from here. Now as it descends down, if it is going to pop out from here, let's say this is the sac from where it is going to come out. For the sake of understanding, I'm just going to highlight this. This is the intra-abdominal content that is going to flow through the obturator foramen. Now as it flows through the obturator foramen, it is now going to go through this. And this opening, the sac that is going to come out, the content that is going to protrude through this, as it goes through this area, obviously it is going to compress the obturator nerve. So patient will have features of compression of the obturator nerve. He will not have a classical feature of hernia because it's a very small opening. Now, because it's a very small opening, it is very difficult for the content to protrude out. Right? Now, this small opening that we are given, no, just for the sake of understanding, if I label it, this is your obturator membrane. This is your obturator membrane. This small opening that is present here, this is what we call it as the obturator canal. Through this you will see there is obturator nerve. This is your obturator vessels. This is your obturator vessel, right? So you have the obturator nerve and the obturator vessel protruding through the obturator canal, and when the hernial sac, so let's say this is the hernial sac, when the sac of the hernia is going to protrude through this small cavity, it is going to compress the obturator nerve and the patient is going to become symptomatic in accordance to that. So when we talk about the obturator hernia in general, if I have to add the important points, remember obturator hernia, the usual age of presentation is going to be above 60 years, right? So what is going to happen in age above 60 years? See, there is some amount of fatty tissue which is present in this area, right? So when you examine the obturator canal, that area will have a lot of fat around it, and that fat won't allow the content to enter or the space to become narrower. Now, whenever there's decrease in this fat component, elderly patients, obviously they lose a lot of fat, so that becomes a risk factor. So elderly patients are a risk factor for the development of the obturator hernia because of, number one, there is excessive loss of fat. At the same time, there is ligament laxity. The ligaments are going to become lax. There's laxity. There is a laxity of the ligament, and that laxity of ligament will cause more compression, right? Hi Shubham, good evening, right? So that is why obturator hernia more common in elderly patients. Second thing you'll notice that it is more common in females when compared to males. It is more common in females. In fact, when you talk about the ratio male to female in an obturator hernia is going to be 6:1. It is far more common in females when compared to males, right? Now, we say any swelling that is going to go under the Cooper's ligament. We have learned yesterday, no, Cooper's ligament यहाँ पे है, ठीक है? So this is the territory of the Cooper's ligament. So lacunar ligament यहाँ पे होगा, यहाँ पे ये आपका Cooper's ligament है. So any swelling that goes on the under surface of the Cooper's ligament will usually develop into a obturator hernia. Usually develops into an obturator hernia. That's a basic concept that we all understand out there. ठीक है? Now, when you talk about the clinical presentation, they do not have any swelling, right? Usually, they will present to you with two complaints. Number one, there will be some amount of inguinal pain and discomfort. There's some amount of inguinal pain and discomfort. Nothing more than that. So because the patient has presented to you with inguinal pain and discomfort, I would like to examine. So when we examine this patient, we are going to examine the patient. On examination, there are two findings. Number one is your Hauschip-Romberg sign positive. There is a Hauschip-Romberg sign positive. Another very popular sign that you will see is what we call as the Hannington-Kiff sign, right? Now, as a, I would say, for a general surgery posting, whenever you go, you need to understand these two findings. One is a Hauschip-Romberg sign. Another one is your Hannington. Somebody from class 9th is attending our lecture, no? Hannington-Kiff sign. Okay. Yes, I'm so glad that you're in class 9 and you're attending a general surgery lecture. But then again, beta, once you qualify your NEET, get into a medical college, enter into your final year, when you have surgery as a subject, it will be relevant then actually. But who am I to stop from learning? Okay. Happy learning, no problem. So there are two signs that you have. Number one is Hauschip-Romberg sign, another one is your Hannington-Kiff sign. Okay. Now what is this Hauschip-Romberg sign? Now we say Hauschip-Romberg sign. So how do you demonstrate this Hauschip-Romberg sign? You will ask the patient to lie down, and then I am going to semi-flex the knee. I'm going to semi-flex the knee and then cause medial rotation. Now when you semi-flex the knee and result in medial rotation, you see there will be a shooting pain, presence of shooting pain along the course of the obturator nerve. Along the course of the obturator nerve, right? Okay. Beta, yes, how to prepare NEET in class 9. Beta, like I have finished my class 9, God knows, मुझे तो याद भी नहीं है कब खत्म गया था यार, ठीक है? So I'm not a right person to tell you that when to start preparing. I hope it is early. Our days we used to start preparing in our 11th standard onwards. तो 11th 12th पढ़ लिया, उसके बाद एग्जाम निकाल लिया तो हो जाता था. अभी शायद गेम थोड़ी डिफरेंट है, ज़्यादा एफर्ट लगेगा तो देख लीजिएगा. आई हैव नो नॉलेज अबाउट इट. हाँ, नीट पीजी कैसे निकालनी है, हाउ टू बिकम अ स्पेशलिस्ट और अ सुपर स्पेशलिस्ट, आई एम योर गाइड फॉर दैट. बट बेटा डाउन इतना नॉलेज नहीं है कि कब से पढ़ना है आपके नीट यूजी के लिए, ठीक है? आई थिंक यू हैव अ लॉट ऑफ एजुकेटर्स एट पीडब्ल्यू हु विल बी more than happy to help you, so kindly reach out to them as well. Okay. Now when it comes down to the Hannington-Kiff sign, now Hannington-Giff sign is basically described in which there is an absence, there will be absence of adductor, that is adductor reflex of the thigh. Adductor reflux of thigh. There is an adductor reflux of the thigh, right? But then one more thing, you'll see there will be presence of positive patellar reflex. So you will see, when you actually do a tapping on the medial epicondyle of your, let's say, the knee joint, it could be femur or it could be tibia. Either ways, you will be able to elucidate the Hannington-Giff sign, right? Now, it occurs when usually when the obturator nerve is getting compressed. So what you have to do is, you are going to tapping over the medial epicondyle. The medial epicondyle of femur, or I can say the medial condyle of the tibia, or the medial condyle of tibia. So when you look at this representation, I can say, so this is how your femur would be oriented, and this is how the joint would look like. I can say this is the medial side, this is the lateral side, this is the medial epicondyle. In the same way, you will have the tibia also, and this is the medial condyle of the tibia. This will be the medial condyle of the tibia, right? So either you're going to tap the medial epicondyle or the medial condyle of the tibia when you tap this, right? So when you tap this, you should see that the adductor muscles of the hip is going to contract. The adductor muscles of hip will contract. Now, as it contracts, you will see the knee joint will move closer to the medial aspect. So initially what you will do is, you'll ask the patient, let's say we'll make the patient to sit on a stool. Let's say the patient is sitting on a stool. This is the stool that we have arranged. I'm asking the patient to sit on this particular stool, right? Now you have the two components here, just to make it more dramatic. This is the hip joint, and let's say this is the knee joint. Okay. Now let's say the patient is suffering from one of the sides obturator hernia. किसी एक side का decide कर लेते हैं. Imagine that the obturator hernia is present. So this is the right side, this is the left side. Right side पे obturator hernia is present. So what I'm going to do is, when I'm going to tap, so when I'm tapping on the medial epicondyle, when the adductors of the hip are going to contract, you will see that the knee joint will move closer, or it will move closer to the medial aspect. So ask the patient to split the legs wide open, do this, and you see the, the legs are going to move closer, or I can say the knee joint will move closer or to the medial aspect of the midline. And this is what we call it as a positive Hannington-Giff sign. Basically, it is telling you there's a compression on the obturator nerve, right? Hannington-Giff sign basically tells you that there is presence of compression. There is presence of compression. There is presence of compression on obturator nerve. So two things, Hauschilp-Romberg sign, where you have semi-flexed knee and medial rotation causes pain along the obturator nerve, which is on the medial aspect of the thigh. So this pain on the obturator nerve is usually going to be on the medial aspect of the thigh. On the medial aspect of the thigh, right? And then the Hannington-Giff sign. So two things that you're going to see here. One is a Hannington-Giff sign, another one is your Hauschilp-Romberg sign, right? Another thing that you can see, especially in females, because it is more common in females, when you do a per-vaginal examination, it's not always, but when you do a PV examination, that is a per-vaginal examination, on a PV examination, what you can feel, that you can have a tender swelling, presence of, or you can feel a tender swelling on the medial aspect, that is of the obturator foramen, in the region of obturator foramen, in the region of the obturator foramen. right? Now again, you do not have any classical presentation for these patients. So whenever in doubt, right, the investigation obviously that you have to do, number one, you would do an ultrasound, but the investigation that I would rely on is going to be CT abdomen. Now this gives you a clear cut, at least an indicative picture of how or what an obturator hernia would actually look like, right? Yes says, I finished my class 11th half bio, please motivate me. Beta, the only motivation that you require is to become a doctor, and to have that dream in itself is actually a motivation. Now you have to get into that 1-2% of the crowd. So what the other the 98% are not doing, you have to do it, be consistent, keep continuing the effort, think about a bigger cause, and don't demotivate yourself. Okay? So continue. Getting into this profession is difficult. Only guys who have done that difficult work will be able to sustain, because journey और भी लंबी है और भी difficult है. ठीक है? तो डॉक्टर बनना relatively आसान है. एक बार बनने के बाद इस जर्नी को कंटिन्यू करने के लिए स्टील का हार्ट लगता है, और तो और ज्यादा दिक्कत और ज्यादा स्ट्रांग होना जरूरी है. तो अभी यही से प्रैक्टिस करना जरूरी है. तो यू विल स्टार्ट बीइंग दैट सेल्फ फ्रॉम नाउ इटसेल्फ, कि आगे चल के अगर आपको सर्जन भी बनना है, यू हैव टू डू योर 5.5 years ऑफ MBBS, 3 साल की जनरल सर्जरी, देन यू बिकम अ सर्जन. ठीक है? उसके आगे अगर आपको और स्पेशलिस्ट बनना है, यू वांट टू बिकम लेट्स से एन ऑन्को सर्जन और अ GI सर्जन, और यू वांट टू बिकम अ कार्डियोथोरैसिक और अ न्यूरो सर्जन और एनी अदर फॉर्म ऑफ सर्जिकल स्पेशलिटी, उसमें 3 साल और इन्वेस्ट करने. एंड देन अगेन फॉर एवरी सिंगल स्टेप देयर इज अ एग्जाम. नीट यूजी के बाद जब आप आओगे, उसका नीट पीजी दोगे, नीट पीजी करने के बाद जब सुपर स्पेशलिटी के दोगे, नीट एसएस दोगे, दैट इज सुपर स्पेशलिटी. तो हर मोड पे आपको टेस्ट किया जाएगा. तो यू नीड टू बी स्ट्रांग एंड कंटिन्यू टू स्टे स्ट्रांग. सो इट्स नॉट दैट इजी, बट होल्ड ऑन टाइट. ठीक है? तो मैं ऑब्ट्रेटर हर्निया पे थोड़ा फोकस कर लूं. अच्छा, वन मोर वेरी इंटरेस्टिंग थिंग अबाउट द ऑब्ट्रेटर हर्निया इज कि ऑब्ट्रेटर फोरामेन इज क्वाइट स्मॉल. ठीक है? Now, because the obturator foramen is small, let's say the obturator opening per se is small. If I give you a 2-dimensional image, let's say this is the obturator foramen, which is quite small. And let's say that this is the peritoneal sac that is going to pop out through this area. So this is the sac that is going to come out. Now you need to understand that the bowel that is present is slightly bigger in size when compared to the lumen. So when the bowel is trying to enter, not the entire circumference of the bowel will be able to enter, only a part of the circumference of the bowel. पूरा bowel नहीं जा पाएगा. bowel का एक end जो है, only a small part of the bowel that is present will enter into the sac per se. तो आप देखोगे ना, पूरा bowel नहीं enter है, only a part of the circumference of the bowel, not the entire bowel. So whatever content is there, the content which is present here, even if it gets obstructed, there's a passage for the content to flow. Now, this form of hernia, where some amount of bowel is present inside the sac and the rest is not, that is only a part of the circumference of the bowel forms the content of the sac, this is what we call it as Richter's hernia. So usually, when you have a patient of obturator hernia, they present to you as a presentation of a Richter's hernia. Richter's hernia, it's where the part of the circumference of the bowel, forms the content of the bowel. It forms the content of the bowel or the content of the sac, not the entire bowel itself. Problem here is Richter's hernia usually presents to you with GI symptoms. Now, what are GI symptoms is, it usually presents to you with GI irritation, and that is usually going to be associated with diarrhea. So you can see obturator hernia patient, elderly female, presenting to you with diarrhea. Okay? So that is also quite possible in the obturator hernias, right? Now, majority of the patients, when they come up with the presentation, they usually land up with obstruction. So the complications are also there. There's increased risk for strangulation as well as obstruction due to narrow opening. So when they come in this particular position, majority of them, they have to be taken for laparotomy. They have to be taken for laparotomy, especially when you are having a risk for obstruction or strangulation. Otherwise, if it's a preoperative diagnosis, let's say if there is a pre-operative diagnosis for obturator hernia, let's say you have already diagnosed this as an obturator hernia before the surgery, then the ideal scenario for this patient is going to take the patient for ideal scenario that you have to take this patient for laparoscopic surgeries. So pre-operative diagnosis will take for laparoscopic surgeries. And in laparoscopic surgeries, we have both the options, that is TAPP as well as TEP. We've already discussed in a short brief. We look into it, what is TAPP stands for and what does TEP stands for. Now, when I say TAPP or TEP, TAPP stands for trans-abdominal. It is a trans-abdominal pre-peritoneal repair. Whereas TEP stands for total extra-peritoneal repair. TEP stands for total extra-peritoneal repair. Okay. Now, in a standard surgery where you have done laparotomy, you are going to reduce it, and after reducing the hernia, same hernia techniques are used. Nothing changes. The only thing is the reduction is via the laparotomy, because we exactly don't know where exactly the site is. But when doing a laparoscopic surgery, TAPP will give you a much easier access. So it is much better in terms of obturator hernia. Now, there's a lot of question around that, in tab when you place the mesh, what is that component called as? Now, I want you to understand a small concept which is called as the myopectineal orifice of Fouchard. Now, I don't think that we have discussed this before. We'll just try to understand the myopectineal orifice of Fouchard, that what it is, what are the boundaries of it, and how it is formed. So we'll try to understand, because when you put the mesh, it actually covers that entire area of the myopectineal orifice of Fouchard. The myopectineal orifice of Fouchard. And this is where we are going to put the mesh. So the myopectineal orifice of Fouchard. Now let's understand what is this myopectineal orifice of Fouchard. Where exactly would you see this, right? So same thing. You have the anterior superior iliac spine, the pubic rami, the pubic tubercle, the pubic symphysis, and this happens to be the pubic bone. So you'll have the same context which is present. Now, one of the most common things that you will see is going to be your inguinal ligament. I've been crying my soul out that it is going to be from the anterior superior iliac spine. It is going to be from the anterior superior iliac spine to the pubic tubercle. Then we also said that when there is an internal oblique and the transverse abdominis together, when they combine, they form into a tendon, and that tendon is what we call it as, it is going to arch out like this, and this tendinous arch that is going to be present, this is what we call it as a conjoint tendon, right? So the conjoint tendon is actually a combination of the internal oblique and the transverse abdominis. When they combine together, they form this conjoint tendon, right? So you have the inguinal ligament, you have the conjoint tendon, and then there is a muscle which is present. The muscle that is present on the lateral aspect covering this area. Now the area where this muscle is going to be present, and this muscle is what we call it as the iliopsoas muscle. This is your iliopsoas muscle. Just for the sake of understanding, I'm just going to label all of them. This is your conjoint tendon. This is the conjoint tendon. This happens to be the inguinal ligament. This is the iliopsoas muscle. This happens to be the iliopsoas muscle. Then we have the same thing. This is the lacunar ligament which is present here. This continues as the Cooper's ligament which is here. So this is the Cooper's ligament. This is your lacunar ligament. This is a thin fibrous septa. Right next to it you have the common femoral vein that is present. And right next to it you have the common femoral artery, right? So the common femoral vein and the common femoral artery, this is going to be present, right? Now, when you look at the boundaries that are going to be formed for this, right? So originally talking, you have one boundary which is formed by the conjoint tendon. So if I just make the conjoint tendon a little bit more convincing for us. So this is how the conjoint tendon would look like. So a little bit more arching towards it. So this is a conjoint tendon which is present here, right? Now, the myopectoral orifice of few chart, just for the sake of understanding, I'm going to label their boundaries. So we have the lateral boundary, we have the medial boundary, you have the superior boundary and the inferior boundary. The lateral boundary is formed by the lateralmost muscle, which is going to be your iliopsoas muscle. So this is formed by the iliopsoas muscle. The lateralmost boundary is formed by the iliopsoas muscle, right? Then you see the medial one. The medial boundary is going to be formed by the muscular component which is here, and the muscle which is present here is your rectus. On the medial, conjoint tendon is going to merge with this rectus abdominis muscle. So this merging is going to be with the rectus sheath, and this is going to be your rectus abdominis muscle. So I can say the medialmost boundary. The medialmost boundary for this muscle is your rectus abdominis muscle. So medial is going to be the lateral border. It is the lateral border of the rectus abdominis muscle, right? Now, when you say this superiorly, so we have the lateral boundary of the medial boundary. Now, this you say is the superior boundary. The superior boundary is formed by the arching fibers of your conjoint tendon. It is the arching fibers of conjoint tendon. It is the arching fibers of the conjoint tendon, that is a superior boundary. When you look at the inferior one, inferior is formed by what is this? We've already marked it down. What is this? This is your Cooper's ligament, right? This is your Cooper's ligament. This happens to be our lacunar ligament, right? This is the inguinal ligament. The green one is inguinal ligament. We'll follow the same color code that we have done before also, no? So this has to be orange. So this is your Cooper's ligament. Okay. So inferiorly it is formed by your Cooper's ligament. So this is the Cooper's ligament that you have. This is your Cooper's ligament. So inferiorly it is formed by your Cooper's ligament. And this is what we call it as, the myopectineal orifice of few chart, right? So this myopectineal orifice of few chart, if I have to anchor it down for you, right? So the anchoring part will be in this area. So arching muscle fibers on top, ये आपका superior हो गया. Lateral is going to be iliopsoas, inferior is going to be Cooper's ligament, medial is going to be rectus abdominis muscle. So one area, this area that I'm shading, no, this is what we call it as the myopectineal orifice of few chart. This is what we call it as the myopectineal orifice of few chart, right? This is what we call it as the myopectineal orifice of few chart. Now why it is important is, अगर मैं इस area पे at the myopectineal orifice of few chart, if I'm covering a mesh, I take care of all the three entry points of your hernia, that is your inguinal hernia, the femoral hernia, as well as your obturator hernia. So the myopectineal orifice of few chart. So when we talk about the myopectineal orifice of few chart, the myopectineal orifice of few chart, when you put the mesh across here, you are going to cover three important sites of hernia. So mesh at this site. If you put the mesh at this place, if you cover the myopectineal orifice of few chart with the mesh, you cover your inguinal hernia, you cover your femoral hernia, and you also cover your obturator hernia. Now the advantage of this is, when you put a mesh across here, no, let's say you're repairing for inguinal hernia, if for future on that side you also prevent your femoral and obturator hernia. So that is a great advantage of putting the mesh in the myopectineal orifice of few chart, right? Okay. Clear? So this is all that you should know in the context of obturator hernia. Let's have a quick recap on obturator hernia. Sabse pehle you should know what is an obturator canal or the obturator opening. That is going to be on the medial aspect where you have the obturator membrane. What passes through the obturator membrane? You have one nerve, one artery, one vein, and the sac, when it comes, it compresses the obturator nerve. So patient will have features which are suggestive of obturator nerve compression. Now once you have this, usually it is seen in elderly females. Reason why elderly? Because less amount of fat, so the compression on that particular foramen becomes much more easier or opening. At the same time, the ligament will become lax, so hence they become more crumpy and hence causing more compression on the nerve. Okay? Now again, when you talk about the presentation, they usually do not have a classical presentation as hernia. They usually present you as pain in the inguinal region or discomfort. When you examine, there are two signs. One is your house-shape Romberg sign. When you have a semi-flexed knee with medial rotation of the hip, actually you will be able to achieve pain along the obturator nerve. That is your house-shape Romberg sign. Hannington-Kiff sign basically cause an abductor. So there is a adductor of the hip to get stimulated when you tap on the medial epicondyle or the medial condyle of either. If you're calling epicondyle, we're talking about your femur, and the condyle is about tibia. When you do that, it is getting stimulated, again telling you that there is an obturator nerve compression. So two important signs clinically, house-shape Romberg sign and Hannington-Kiff sign. Both of them are seen in your obturator hernia. Again, the management is quite simple. Presentation, as I told you, one form can be of because of Richter's hernia. It's a form of hernia where a part of the circumference of the bowel, not the entire bowel, forms the content of the sac. And when that happens, so patient usually present with GI symptoms, that is diarrhea, and then you diagnose that with the help of CT. Take usually for exploratory laparotomy when you're taking for an open repairs. Otherwise, take for, if it's a pre-operative diagnosed case, go with TEP and TAP. That you have TAP is preferred over TEP because it gives you more access. What you're going to do, you're going to put the mesh in the myopectoral orifice of future. This covers this area. When you put the mesh from inside, this blocks this area. Now that area, again, all the boundaries of the myopectoral orifice of future is important. Lateral is iliopsoas muscle. Medially, it is going to be the rectus abdominis muscle. Superiorly by the arched fibers of the conjoint tendon. Inferiorly by Cooper's ligament. Again, do not try to mug it up. If you understand this area, we've been revisiting again and again in all our hernia lectures. So you should be quite confident in talking about this area, no matter how it comes. Okay? So with that, you need to know whatever about obturator hernia is being covered. If you have any questions, any queries, feel free to ask. Otherwise, we'll keep a short session today. We'll resume back next week. You know where to ask your questions. You can send your questions to our Instagram channel. That is your surgery guy. It is by my name, and you know my name. It is Dr. Sandeep Seeram Reddy. Okay? कोई सवाल, कोई शक, कोई doubt, कोई suggestion, feel free to reach out. Okay? Until then, thank you so much for joining today. We'll resume back next week. Happy Mahashivratri to all of you and have a good time. Right? Thank you guys for joining. Signing off for today. Goodbye.